So hello all. My name is Dr. Nabulindo. I'm your moderator today and also the Secretary of the Kenya Society of Anesthesiologists. So welcome to today's continuous medical education organized by the Kenya Society of Anesthesiologists in partnership with the Critical Care Society of Kenya. So today we are privileged to have specialists in the area of intensive care medicine and pulmonology joining us from other specialties to talk to us about high flow nasal cannula with oxygen therapy. All of us know now that oxygen therapy has become a big thing. Although most of us are anesthesiologists, we have been using oxygen, but now it has become a commonplace name even for the lay person. Our politicians are always on media talking about oxygen. High flow nasal cannula is not something that has been with us as a common device we use to deliver oxygen. And today we shall be privileged to have some of our specialists who have used this talk to us about this, because going forward, you probably will see this in your hospitals. So our talk today is on high flow nasal cannula. Our presenter and speaker is Dr. Kaiser Fitzwanga, who is a pediatric critical care specialist. And in terms of introducing her, I would like to fully introduce her as an alumni of Makerere University, where she did her MBCHB. And then she joined us at the University of Nairobi here in Kenya to study a master's in pediatrics. So following that, then she went to University of Cape Town, where she studied, or rather specialized in pediatric critical care. So she has great passion for pediatric critical care medicine, and currently she is working part-time at the MPSHA Pediatric ICU, and also involved in aeromedicine with the AMREF flying doctors. She completed her fellowship at the Red Cross War Memorial Hospital about 4 years ago, and is a fellow of the African Pediatric Fellowship Program of the University of Cape Town. She has also previously worked in various hospitals and various countries, South Africa, Lebanon, mainly dealing with critical care medicine and also aeromedicine. She also has worked in various critical care units in our country, Nairobi Hospital, Aga Khan, MPSHA, and is an instructor involved in the Critical Care Society of Kenya, teaching the basic assessment in critical care course. Dr. Kaiser, again, I'm proud to say that she's always one of the partners with the anesthetists, especially those who deal with children, and she's always joining our CME and contributing in the improving care of children, where she has been a very good supporter for the anesthetists. Welcome, Dr. Kaiser. We are privileged to have you as our speaker today. So with her is a panelist who is Dr. Andrew Owuor. Dr. Andrew Owuor is a physician specialized in pulmonology at the Kenyatta National Hospital. And he also works in the medical critical care at the Kenyatta National Hospital and various private hospitals in Nairobi. So basically also quite up with the matters of COVID, and he has been very active treating these patients, especially patients ending up in critical care requiring reviews of a physician pulmonologist around this period. So we shall be privileged again to have his input with this particular topic. Welcome, Andrew. We are privileged to have you. Then my co-moderator will be Dr. Sally Gitugi. Sally Gitugi is a final year master's student in anesthesia in the Department of Anesthesia, the University of Nairobi. Today's CME has been sponsored by Crown Healthcare in partnership with Equity Bank, and we shall have brief presentations at the end from our partners to tell us what they are doing to support us as critical care specialists and anesthesiologists in this time. Thank you very much. So for some housekeeping, again, your mics will be muted throughout. Try to also keep your cameras off so that you have a better bandwidth so the speakers are clear. If you have any questions as the speakers go on, you can put on the chat and we'll pick it up. At the end, if you feel you want to make a comment, then use the raise hand function of the meeting, and we shall be able to give you a chance to talk. So without further ado, I would like to welcome Dr. Kaiser Fitzwanga to take us through the topic of today. Welcome, Kaiser.
Thank you very much, Susan. I'm very humbled by your introduction of myself, and I'm privileged to be partnering with the anesthesiologist. And today I will be taking us through high flow nasal cannula therapy, how, when, and why. Okay, so as an introduction, so is my slide moving?
Not yet, Kaiser.
Okay, all right, okay.
Now
So as an introduction, this is basically, your apparatus for your high flow nasal cannula, and it consists of pretty much 4 parts. So you have your air oxygen blender right over here that you'd use to attach to your flow meter, that you would use to determine your flows and your fraction of inspired oxygen. Then you have your oxygen now coming to this active humidifier where your gas is actually heated and humidified. Then it is then now transmitted to the patient via heated inspiratory circuit, which is a single limb via nasal cannula. Basically, that is what the whole apparatus is about. And you can set your oxygen from a range of 21% to 100% with maximum flows of 60 liters per minute. I must say that they usually come in 2 types, which I'll talk about, the 2 different devices in the unit, in the market. So you have the OptiFlow by Fisher and Paykel, this one on the left, which is available in some of the hospitals in Nairobi. I think MP Shah has it, and I think Nairobi Hospital, and then the VapoTherm one. Okay, so they normally come with 2 circuits. It's either a pediatric circuit or an adult circuit, and the maximum flow in the pediatric circuit is 25 liters, and the maximum flow in the adult circuit is 60 liters per minute. How does this, what is the mechanism of action of your high flow nasal cannula therapy? So from this diagram, yes.
Dr. Kaiser, may I interrupt you a bit? Maybe if you just adjusted your mic and move closer, you are not so clear. So maybe just adjusting your audio a bit, maybe move closer.
Can you hear me now? Sorry. Okay, am I audible now?
Yes,
am I clear?
Audible. Yes, you are clear.
All right. Okay. So maybe I'll just go back a bit. So these are the 2 high flow nasal cannula devices in the market. That's the OptiFlow on your left, the blue one by Fisher and Paykel, which is a company in New Zealand, and this is the VapoTherm. The one that we have available in Kenya is the OptiFlow by Fisher and Paykel at MP Shah and Nairobi Hospital. I'm not sure about other facilities, but this is what we have available in the country. So how does your high flow nasal cannula therapy work? one, because of the high flows, you know, at the wall, when you insert your flow meter at the wall, it comes at 3 to 4 atmospheres, which is about 2,000 plus millimeters of mercury pressure. So with that pressure, you then have that oxygen being delivered at high pressures, causing nasopharyngeal washout of your carbon dioxide. So then you have reduction in your anatomical dead space, and that translates to increased work of breathing. There have been studies that have shown that high flow nasal cannula therapy has a PEEP effect from studies by Coley et al. That show with the electrical impedance tomography that showed that it high flow nasal cannula therapy was giving PEEPs of between 2 to 8 centimeters of water. And this has effect of improving your end expiratory lung volume, which is a surrogate for your functional residual capacity. And with that, then you have better alveolar recruitment. You have preconditioning of your expired gas because it is heated and humidified. There's better comfort and tolerance because you have provision of heated humidified gases via nasal cannula, which is not claustrophobic on the face. And with that also, the patients have better mucociliary clearance. So how does high flow nasal cannula compare with other oxygen delivery devices? Let's start with the common one, the low flow. So the low flow includes your nasal cannula, your face mask, and your non-rebreather face mask. We know that the maximum flow in this low flow delivery devices is 15 liters per minute. So when you look at your nasal cannula and face mask, you have generally patients who are in respiratory failure tend to have very high inspiratory flows from 30 milliliters per minute to up to 120 liters per minute. However, because your low flow devices are a maximum of 15 liters per minute, then you find that their inspiratory flow exceeds the supplemental oxygen flow. So what happens? Then you have entrainment of room air and oxygen dilution. Hence, your delivered FiO2 is not very accurate, and especially like your nasal cannula, there's a rule of 1 to 4 for every 1 liter of oxygen, and you have an increment of 4% above your room air. Delivery devices like your Venturi mask. Your Venturi mask will provide pretty much a predictable FiO2 because you have this regulator here that regulates the amount, you know, it titrates the ratio of your supplemental oxygen to room air, and they are color coded. So based on the color codes, then you select depending on the amount of oxygen you want to deliver. However, the Venturi masks still have issues of entrainment of additional room air around the mask. So you still will have dilution of oxygen and lower fractional inspired oxygen concentration.
Hello, Dr.
When we
Hi,
hello.
Dr. Hi, Dr. Kaiser.
Hi.
Just
Hi.
to
Can you?
it looks like your speaker. Are you using a headset or directly on your computer?
Directly on my computer.
Okay, I think your speaker is the one with a bit of noise. I don't know if we can improve.
Sorry?
Further. I mean, it looks like your speaker has a bit of noise. Okay. But if you can't do anything about it, then we can continue. But if you can improve or maybe use a headset if you have one to see if the microphone will improve a bit.
Okay, let me just change to a headset then.
Yes, yes. Kindly, participants, just a minute as she tries to improve her audio.
Hello, can you hear me now? Am I clearer now?
Yes, I think the speaker interference is a bit better. Just go on, we shall see how it goes. Yeah. Thank you.
Okay. 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 Do you want me to go back to the? Okay, thank you. Do you want me to go back to the last slide, or shall I proceed?
Maybe the last one before this one, and then we proceed.
Okay. All right. Okay. So I just after taking us through the mechanism of action of how the high flow nasal cannula works, I thought it would be nice for us to have a comparison with other oxygen delivery devices so that we can now get a proper understanding, and then that helps us in decision making. So we were just comparing with the other oxygen delivery devices, and I was going through the low flow oxygen delivery devices like your nasal cannula, your face mask, and then with the face mask. We know that the flow is limited to a maximum of 15 liters per minute. And because patients with respiratory failure tend to have high inspiratory flows, up to 120 liters per minute, there is usually a mismatch between the patient's inspiratory flow and the supplemental oxygen flow with the low flow devices. So you find that because of that, then you have entrainment of room air and hence the dilution. Okay. When you look at the Venturi mask, it has a more predictable oxygen fraction of inspired oxygen because it has a regulator that will regulate the ratio of supplemental oxygen to room air. And there are different color codes depending on the amount of oxygen, supplemental oxygen percentage you want to give to the patient. And those who have low oxygen requirements, the Venturi mask provides higher flows due to higher air entrainment and vice versa. However, these masks are not perfect because you still have additional entrainment of room air around the face mask to meet the inspiratory demand of the patient. So you still eventually get dilution of oxygen delivered to the patient and hence a low FiO2. When we compare with NIV delivers pressure targeted breaths by varying the inspiratory flow. So you have this face mask that usually has to be tightly secured around the patient's face to avoid leaks and room air entrainment. And the PEEP and the FiO2 are set independently. So why the comparison with high flow nasal cannula? As you can see, for the high flow nasal cannula, the fact that you don't have all these contractions on your face and tightness, you have better tolerance for the patient. And because it has your effect of giving your PEEP and reducing your anatomical dead space, then you have optimal improvement in your oxygenation and alveolar recruitment by increasing your FRC. So what are your indications for high flow nasal cannula therapy? Respiratory failure, which can be acute or chronic, or as a step down or step up therapy. Neuromuscular weakness patients. These are the patients that you normally we try as much as possible to avoid invasively ventilating them because they're difficult to actually liberate from invasive mechanical ventilation. So those patients that have respiratory failure and have hypoxemic, moderately and mildly, you can start them on high flow nasal cannula. And of course, the advantages of easily tolerable. And then also patients with obstructive sleep apnea. These are the contraindications of your high flow nasal cannula. You have your absolute, like a patient who is apneic is a no-no, a patient who is in shock or cardiopulmonary arrest, or life-threatening hypoxemia, with the exception of patients who are you are palliating. Okay, then you have your relative contraindications, your complications. Of course, the commonest is failure to recognize deterioration, non-compliance, a patient who is very agitated, but however, it's really uncommon, gastric and abdominal distension, aspiration, pneumothorax, and inadequate gaseous exchange, among others. So when it comes to selection of patients for high flow nasal cannula, you want to first ensure that they have absence of contraindications to the therapy. they must have an adequate respiratory drive. They must have the ability to protect their airway and the high likelihood for them to tolerate the therapy. Fortunately, most of them tend to tolerate the therapy. That's adults and children. And when you decide that you want to start them patients on high flow nasal cannula, you must have a reasonable expectation that it will stabilize or reverse the respiratory status as at assessment. So generally, this is, when you're faced with this hypoxemic patient, generally you start with, your conventional oxygen therapy with low flow devices. So by the time you get to mechanical ventilation, because most of the time then, so it would either be, you're on a low flow oxygen, your conventional oxygen therapy devices, and then they deteriorate and then you intubate them and mechanically ventilate. But now with the studies that are showing the benefit of your non-invasive ventilation, so you have room to actually play around, let me not use the word play around, but you have room to actually titrate your devices for administration of oxygen therapy. However, the caveat is you should not delay for a patient to actually urgently need intubation and mechanical ventilation. So how do you initiate it? You want to select an appropriately sized nasal cannula and circuit for the patient. With the OptiFlow device that I showed you, they pretty much come with two sets of cannula and circuits. It's either the adult or pediatric. The recommendation, and this is where I have seen in some places that have worked, that people think that the nasal cannula must occupy the internal diameter of the nares. It must occupy 50% of the internal diameters of the nares. Why is that? Remember, at your oxygen source, you're delivering high flows and high pressures at 3 to 4 atmospheres. So this having the diameter of your nasal cannula 50% acts as a pop-off valve for your pressures. If you get cannula, like if someone gets tempted to use CPAP cannula that must occlude the diameter of the nostrils, these are the kind of patients who start getting, emphysema and the head blows up because of the pressures and the gas, subcutaneous emphysema. Then the clinician determines the delivery settings. So usually the two delivery settings that the clinician determines is, of course, your FiO2, which is determined by dialing at your flow meter, and your flow rate. In pediatrics, this varies by the age and size of the patient and the severity of disease. We usually start at 1 to 2 liters per kg. So actually, we start at 2 liters per kg for the first 10 kilos. Then after that, it's 1 liter per kg. So depending on the severity of the disease and the acuity of the patient, you may decide to start at 1 liter or 2, because 2 liters per kg is quite high. For the adults, because if you're to go by generally 1 liter per kg, the maximum flow that the adult circuit gives is 60 liters per minute. And taking an average male of 70 kilos, you start directly at 60 liters per minute. Then things like the air temperature is usually preset, like the OptiFlow, the Evo machine, is pretty preset at 37 to maximize humidification. So most of the times we don't actually interfere with the air temperature. So you must assess the effectiveness of high flow therapy, because as I said, one of the complications is failure to recognize deterioration. So what are the parameters that you look at? Vital signs, because generally we know compensatory mechanisms. When a patient has respiratory failure, they get tachycardic, they are tachypnic. So when I start this patient, I've assessed that they actually are suitable candidates for high flow nasal cannula, then I must see a reduction by 10% from the baseline of their heart rate and respiratory rate. And this responsiveness must be assessed within an hour of therapy. If within an hour of therapy, there has been no change, this is most likely a patient who is likely to fail high flow nasal cannula. And at that point, then you want to start assessing how
do you need to escalate? And of course, if you're doing other surrogates or oxygenation like your PF ratios, then it will actually guide you in terms of, this is a patient that I may need to intubate and mechanically ventilate. I may want to, depending on other things like the state of mental status, because if they are getting really drowsy and all, then I wouldn't want to start now trying them on non-invasive positive pressure ventilation with a face mask. These are patients that I would just want to intubate and mechanically ventilate. You want to also assess their work of breathing, because we know that high flow nasal cannula therapy significantly offloads the work of breathing. So you can assess this clinically. And in pediatrics, we have scoring systems like the PIS that's used in asthma and bronchiolitis. But if you, the quicker one is just looking at your work of breathing clinically. If you don't have access, because these are usually, you should have those tables in your unit that you can quickly calculate a score. But just eyeballing at the patient, looking at their recession, is the breathing getting quieter, quiet, not in an ominous way, but better in terms of they're not struggling to breathe, the intercostal recession, the subcostal recession, the use of the accessory muscles. Those are the other surrogates, okay? Then your oxygen requirement is another assessment. Your oxygenation generally should improve by the mechanisms that are mentioned. So these are patients who you should be able to start titrating down your FiO2. So what is the evidence in adults? There have been several studies that have shown the benefit of high flow nasal cannula in adults. So in one of the indications was in acute hypoxemic failure, where use of high flow nasal cannula demonstrated higher SATs, higher partial pressures of oxygen, lower respiratory rates, and these patients were more comfortable when HFNC was compared to traditional oxygen therapy. And there's a big study, the Florali study group. Post-extubation, they had better oxygenation, reduced dyspnea, increased ventilator-free days, reduced intubation requirement when compared to extubating them to non-breather face mask. However, the caveat is, this is for those high-risk patients. This benefit has not been demonstrated in the low-risk patients, because traditionally your low-risk patients, you would extubate them to a non-rebreather mask as you taper down your oxygen delivery devices. Then pre-intubation, it has been shown to improve pre-oxygenation during apneic intubation. So like you initially would pre-oxygenate them with a bag, valve, mask device, and then when they're not breathing, having the nasal cannula during the process of tracheal intubation has been shown to have reduced hypoxic episodes. Acute hypoxemic respiratory failure in immunocompromised patients, this has shown a reduced 28-day mortality in cancer patients in comparison to use of standard oxygen. And then also it has also been shown to alleviate obstructive sleep apnea in patients with sleep apnea. How about in pediatrics? This was a survey that was done in neonatal units in the UK, the US, and Australia and New Zealand, which showed the indication for commencement of use of high flow nasal cannula. And these are the different indications: post-extubation as an alternative to CPAP, weaning off CPAP, patients with apnea of prematurity, infections, and chronic lung disease, and nasal injury. We know, these other devices for providing CPAP, usually because of that seal on the face, it usually tends to, because it sits on the nasal bridge, they tend to get nasal bridge erosion. However, there is the evidence in terms of its early use in neonates is quite slim. In fact, when you look at this study here, comparing high flow nasal cannula to the CPAP group, you can see that the treatment failure within 72 hours for preterms and patients, preterms less than 32 weeks and those greater than 32 weeks, was significantly higher than the
CPAP, those who are put on a nasal CPAP, okay? There was no difference in terms of the intubation within your 72 hours. However, in terms of your treatment failure, that showed a significant difference. So in conclusion, really, the use of high flow nasal cannula like neonates, early use it actually has no role. I thought I would just put this out here. In pediatrics, however, it has been shown, because now based on other studies, it was then extrapolated to pediatrics. It has shown role for respiratory support in children and for infants with bronchiolitis by improving their oxygenation, reducing the respiratory rate, reducing the work of breathing by these patients. And this is from meta-analysis of studies that have been done in Cochrane review of studies that have been done in pediatric patients. So in summary, this is just a mnemonic for the high flow therapy, where H is the features, heated and humidified gas, okay? I, your inspiratory demands better meet your peak inspiratory demands. And because of higher inspiratory flow, then it overcomes your expiratory resistance in your nasopharyngeal airway. With that, then you have increased FRC through delivery of PEEP. As I said, electrical impedance tomography has shown that it actually improves your end expiratory volumes. It's lighter because it's a mask. It's nasal cannula that sits in the nares. These are patients who can talk and communicate. They can actually even eat, unlike your CPAP or BiPAP masks where you have these contractions on the face that causes this claustrophobia, and it's even more difficult to initiate your CPAP or BiPAP with a face mask, because you have to start titrating slowly, having them to do acclimatization. Then it minimizes oxygen dilution by the mechanisms that I have shown. I have demonstrated, because your inspiratory flows overrides, your oxygen delivered overrides the patient's inspiratory flows. And of course, the most significant, you have your washout of your dead space, resulting in your reduction in your anatomical dead space and CO2 clearance, and better oxygenation at the end of the day. Thank you very much, and my apologies for the technical hitches.
Thank you so much, Dr. Kaiser, and sorry again about the issues that we had, but I hope everyone was able to hear. It was a wonderful presentation indeed, very informative. As I wait for the participants to give their questions, Dr. Owuor, perhaps you can tell us about your experience on the use of high flow nasal cannula therapy, and we can continue the conversation from there.
Good evening to you all. I just want to thank Dr. Kaiser for such a wonderful presentation. High flow nasal cannula has come to our aid in these difficult times of COVID, especially with regards to hypoxemia. I think one thing that we need to clarify is that most of the evidence is for acute hypoxemic respiratory failure. There are still studies ongoing on whether we can use it for the other forms of respiratory failure, but majorly for acute respiratory failure. One of the things that I think is important for those of you who are already using this gadget is that monitoring is very important, just as Dr. Kaiser has mentioned, that you have to monitor the patient, because if this patient requires intubation and you delay, then they're likely to have an adverse outcome.
Thank you, Dr. Owuor.
It would also, yes.
Sorry, that's my mistake. Continue.
So, I mean, it would be interesting to know in the audience how many of you have used or have these gadgets in their facilities. It'd be interesting to know in the audience how many of them have this gadget in the facility. My question to you, Dr. Kaiser, where should we use this high flow nasal cannula? Is it a device you can use in the bedside? You take it to the ward? Is it a device that we probably use in the acute rooms? Or is it a device that we probably just need to use in the ICU?
Okay, thank you very much, Andrew. So thank you very much. So pretty much this device can be used in the acute rooms. It can be used in the emergency department. It can even be used in the wards. My experience in South Africa was we used to use it even in the wards, but you have to train your nursing staff on its use and assessment of these patients, because at the end of the day, if you have equipment that you don't know how to use and you don't know how to assess, then it becomes dangerous, even though it is beneficial to the patients. So it's all about training your nursing staff, your medical officers, your residents on its use. And it's pretty simple for nursing care, because if you're using, say, like for the nursing care, if you're using certain scoring systems, then you have to have it in their, their nursing charts. They must have it, because it's not something that people know on the top of their head. So then it's very easy for them to chart. Or the other thing is just, as I said, the heart rate must come down by 10% of the baseline. The respiratory rate, their oxygen requirements should come down. Their work of breathing should improve. So those are your other ways clinically of monitoring that it's actually working. And people must be obsessive in terms of, within an hour, if it's not working, then this is a patient that you want to call the ICU team, like say if it's in the wards, or in acute rooms, in the side acute rooms in the wards, then they must call for ICU review and for further escalation of therapy. Thank you.
Thank you, Dr. Kaiser. I'm seeing the comments are now coming in. The presentation was very well done. A lot of people are saying it was a good presentation, and thank you for that. The first question comes from Dr. Sheila Gitau asking, how do you wean a patient off high flow nasal cannula therapy?
Okay. So the first thing is you first start, as I said, because it improves the oxygenation from the mechanism I mentioned. Hello, am I audible?
Yes, you're audible. Yes, we can hear you, Dr. Kaiser. You're more audible now.
Okay, thank you. So the first thing that you want to wean is your FiO2. Generally, the same way that when you intubate a patient, you start with an FiO2 of 100, so will you do with a patient on high flow nasal cannula. So the first thing that you want to wean is your FiO2. And that I said you'll dial down your flows. Once you get to your FiO2s of 40, then of course you're still assessing the other vital signs, as I said. Heart rate is coming down, respiratory rate is coming down, work of breathing is improving. Then now you start dialing down your flows, which you dial still at your flow meter, because that's what determines the amount of flow that you deliver for these patients. And also on the machine, it has some buttons that you press to actually calm down on the flow. So it's FiO2 first and then your flows. Usually flows of 8, once you get flows of 8 liters per minute in practice is more in pediatrics, but I'd assume their flow will be something like 10 or 12. Then this is a patient who now you can now change to your low flow oxygen devices. Thank you.
Thank you for that. There's a few people who are asking about the use of high flow nasal cannula therapy, especially considering our pandemic of COVID, with questions on the risk of aerosolization. Would you like to comment on that perhaps?
Okay, so may I just intrigue everyone to know that if you're even using face mask oxygen, as long as you're using flows of oxygen, you have increased risks of aerosolization. And these are studies that were done, these were simulation studies that were done by David S. Hui during the so yes, there are risks of aerosolization. So in the setting of COVID, if you have a patient with mild to moderate respiratory failure, this is a patient that there is benefit of using high flow nasal cannula, and that has actually been sanctioned by the Society of Critical Care Medicine if they are not tolerating the low flow devices as a bridge, because it's either that, or if you don't have high flow nasal cannula, then you can use your NIPPV. But the caveat is, as I said, assessing for effectiveness and not delaying intubation in these patients. In the setting of COVID, of course, you want to make sure your IPC precautions are observed. So you want to be in your full PPE. Okay, so yes, it has its role, but for the COVID-19, full PPE, IPC precautions, and the usual precautions that we say for any, any COVID patient, you want a negative pressure room. Number two, you want to limit the number of staff. So you want to have your most experienced, highly experienced, in case, this patient fails, then directly you're now going to plan for intubation and mechanical ventilation. So this is a patient where you want to have your crash cart ready, you want to have all your drugs for intubation, your different size tubes, so people are not running in and out of the room and breaching the IPC precautions. But yes, it does have a role. Thank you. Dr. Andrew, maybe you might want to add, because you have more experience than I do in terms of the COVID patients, please.
It's just as we've said, that IPC measures have to be taken in place, and that's why I'd asked you, it was a tricky question on where should you use these devices. My opinion, this is not a randomized control study, is that we should, as much as possible, cohort these patients so that you minimize the number of staff who probably be in contact with these patients. So for example, if you have a room, you can have a high flow nasal cannula. One staff can go around the machines in different rooms or in different areas of the hospital, where now there's an increase in the number of staff who be coming into contact, especially with the patients who have COVID. So I am pro cohorting the patients in one area so that one staff can actually sort out many of these patients, rather than having them in different wards and in different places. Two, it ensures that the staff or the nurses who are these patients become very good at actually using the device.
Thank you. And Dr. Owuor, while you're still over here, maybe I can ask the next question to you. Dr. Mayur has asked if you could shed some light on the ROC scoring for predicting high flow nasal cannula failure and the tendency for intubation. And at what point in time would you do it, and how often or at which point in time should you be assessing using a BGA? Sorry, I'm just now mixing questions. So the first part.
So basically.
Sorry, can you hear me?
It's okay. Just to get forward, the ROC score, for those who do not know, is actually a score that you use to actually try and predict the patients who are likely to fail non-invasive measures of treatment. So basically, patients who are on non-invasive ventilation, high flow nasal cannula, and even the patients who are on low flow oxygen. So basically what you do, you want to take your SpO2, divide it by the FiO2, and then that product is divided by the respiratory rate. And if it is greater than 4.8, then the patient will succeed. If it's less than 2.8, then the patient is probably failing, and you want to consider probably advancing to another level of care for this patient. How often should you do it? My proposal will probably, as Dr. hourly, you want to keep even just the patient comfort. If the patient was very tachypneic with a high respiratory drive, then you want to assess and see, has this succeeded? If it hasn't, you want to quickly move to emergent measures and probably intubate this patient without further delay. The biggest challenge with my experience with COVID patients has been delay intubation. So people think it's a holy grail. You put the patient on high flow nasal cannula, they'll be fine, you leave them. And later on, you actually find sometimes the patient is not doing as well as you thought.
All right, thank you. And just to clarify, after you, Dr. Owuor now, as you're trying to wean the patient off the high flow nasal therapy, when you're trying to wean on the FiO2, how do you now step down the flows? Do you do it at an hourly rate, or do you do it at, as the patient is improving? How exactly do you, in your practice, have you been weaning off the high flows?
So as Dr. Kaiser has said, actually, when you start this patient, you want to start with low flow rates, but a high FiO2. So you want to set your FiO2 at 100%, and you want to start with flow rates of, most machines will start from about 20 all the way to about 60 or 70 liters per minute. So you start low flow and with a high FiO2 of 100%, and you keep on increasing until the set targets are achieved, or it becomes intolerable. As the flow rates increase, the device for some patients will become intolerable. They have the flow rates. When you hit flow rates of 50 liters, 60 liters per minute, for some patients, that may actually become quite uncomfortable, because the pressure that they're feeling in the nose is quite high. When you're de-escalating, you'll start with the FiO2 first. So you'll continue reducing your FiO2 all the way to an FiO2 of about 50%. Once you hit 50% of oxygen, FiO2, then you can now start coming down on the flow rates. How often should you do this? There's no rocket science, there's no written science, but for me, for what we do is every hour you want to reduce. If you do not have ABG, then you can use the ROX score, because basically you just need the FiO2, the SpO2, and the respiratory rate for the patient to be able to know how they are doing. Where available, of course, you do a blood gas and check. And see if the blood gas is acceptable, then again, you can continue to reduce. Maybe because in most of our facilities, it may be difficult to do serial blood gases, then perhaps you want to use more of the ROX score to be able to wean off the patient. So hourly, when the patient is getting better, FiO2 of 50, if the flow rates are high, I come down to 60, to 50, to 40. Once I'm at 40, again, I can start coming down on the FiO2.
Thank you so much, Dr. Owuor. Maybe as you take a break, I'm seeing Thomas Kitonga of Crown Health has actually gone on to say that currently we have 192 of the units of the high flow nasal cannula devices in Kenya, 30 are in Kenyatta Hospital, 35 in Kenyatta University Teaching and Referral Hospital, and MTRH has 35 units, with the rest of them spread across the country. His details are also over there for Crown Health in case anyone would be interested to contact him. Seeing Emily has also said that they have 2 machines that can deliver high flow nasal therapy at Aga Khan University Hospital, Nairobi. They have the Drager machine and the Airvo 2 or Fisher 7 PayCal. So that's also assuring to know. Thank you for that. And Dr. Kaiser, maybe I can ask you this question from Dr. Mayur again. For the high flow nasal cannula, specifically the AirVo, does it need a special flow meter to deliver oxygen to the machine? Hello, Dr. Kaiser? Dr.
I think
Kaiser,
she's dropped off.
Okay, that maybe perhaps Dr. Owuor, you can answer the question.
Hello?
I haven't had much experience with the Asia Packet. I think I just got accustomed to it, I think about a week ago. And the device is quite simple to use. And basically what you just use, the tubing, you just use the normal flow meters that we use even for the low flow oxygen therapy. It's the same flow meter. You don't need to use a special device for it.
Hello? Can you hear me? Can I come in?
Yes, please comment, Dr. Kaiser.
Yes, just as Andrew has said, there is no special flow meter. It is the same conventional one that you'd use for oxygen, low flow oxygen therapy. It's because it's what you use to dial your FiO2, because as you dial your flow meter,
Sorry about that. I think we've lost Dr. Kaiser again.
machine, how much the flows now, because the AirVo makes those.
Hello, Dr. Kaiser. We basically cannot hear you at all. Maybe we can continue with the other questions, Dr. Sally, and then when Kaiser comes back, she can comment after network is better.
Okay.
Yeah.
All right then. So Dr. Owuor, to you. Magdalene has asked, how fast do you increase the flow rate before the patient has failed? And maybe coupled with another question, how do you use it in RSI? Or is there a rule for it in RSI?
This high flow nasal cannula hasn't been with us for a long time, about I think now 20 years. Most of the studies haven't been head-to-head studies with other devices, apart I think from the Florali study, where they actually compared it with the low flow oxygen devices that we currently have. With regards to flow rates, they're just like the way we adjust a ventilator. It's gonna be the same. So you want to titrate until you meet your target. So when you're setting it up, you want to start with an FiO2 of 100%, okay? And for example, if the patient's saturations are 68, example, and a respiratory rate of 43, if you start a patient, right, and the FiO2 over 100%, and the saturation for this patient moved to 90, but the patient is still having a high respiratory of 35. Then you floor it so that you reduce entrainment of air. Because when the patient is having those deep gasping, deep breaths, they're actually taking in a lot of air, which tends to dilute and reduce the oxygen within the air. So by increasing the flow rate, you actually reduce the entrainment of air, and consequently it makes it a bit easier and gentler for the patient, and the respiratory rate comes down. So FiO2 100, start the low flow rate, and then keep on adjusting as you watch the patient. So this is not a device where you put the patient, you put a flow rate of 30 and then you walk away. You have to watch and see how the patient is tolerating. Are you meeting your target? The challenge sometimes is you put the patient on an FiO2 of 100%, flow rate of 35, immediately the patient's saturations are 90, everybody walks out of the room. You come back and you find the patient actually arrested. Okay, so you have to be careful and watch and see are all these targets being met. Is a patient comfortable? Because when the patients are hypoxemic, they tend to be a bit psychotic. They become a bit psychotic. They are very restless. Has the restlessness resolved? So all those issues have to be taken in place, because if the patient is still restless, then they can. It's just a nasal cannula. The patient can move it, can remove it, and that could be disastrous, especially if they're on high flow rate.
All right, thank you so much, Dr. Owuor. Dr. Kaiser, again, thank you for the great presentation. A lot of applause and praise from the audience. Dr. Owuor, thank you so much for your insight and for the wonderful work that you're doing in KNH and helping us out for today. Dr. Nabulindo, I think for now.
Can I answer, Sally? There was a question. Now,
Sorry,
there's some aspects of the high flow nasal cannula that Dr. Kaiser did not touch in. Now, for anesthesia, this device is good. So post-operatively, there is some evidence it can be used, especially for thoracic, cardiovascular and thoracic procedures. So post-op, you can actually use this device to actually help you maintain good saturations. There is actually value for using the device for patients during weaning. So once you've weaned off the patient off the ventilator, you can actually use it as a bridge before you get the patient like out of the ICU. So you wean the patient out of the ventilator and also use the high flow nasal cannula. Lastly, there was another indication, but I remember off the top of my head.
Yeah, can I come in?
Yes, Dr. Kaiser, maybe parting shot.
Okay, yeah, thank you, Andrew. Yes, it is. I think I just wanted to touch on, just an introduction to the basics of the high flow nasal cannula therapy. Yes, you have those patients who have been ventilated for a long period of time. Remember, in the past, we would, of course, they've been mechanically ventilated for long, and our only option then in the past was just your face mask with a non-rebreather. But now that we actually have, and I'm happy that we have 192 high flow nasal cannula devices in the country. In fact, now we need to actually go training people and increasing their awareness so that people know that, you can actually quickly transition from low flow devices to a high flow device, and it's simple to use. So for that patient who's been prolonged mechanically ventilated, yes, you can actually use it as a step down, in your respiratory failure, step down from invasive mechanical ventilation. They meet the criteria for liberation from invasive mechanical ventilation. You can use it, as you as they go to the path of recovery. Then eventually you step down to low flow devices, either that or your non-invasive CPAP devices. But the advantage of the high flow nasal cannula is the fact that it's easily tolerable for the reasons that I have mentioned. Thank you.
Thank you so much. I'm seeing Dr. Chikofe has written in the chat box that high flow nasal cannula therapy is useful in RSI for anticipated difficult airway and morbidly obese patients because the continuous insufflation maintains the apneic oxygenation in the FRC. So thank you for that, Dr. Chikofe. So I think at this point in time, I'd like to close the Q&A. Thank you everyone for the participation. Dr. Owuor and Dr. Kaiser, again, thank you for the insight and the wonderful presentation. Hopefully we'll have more discussions in future on this as it's still new to many of us so that we can keep on keeping ourselves updated as we continue. So Dr. Nabulindo, back to you.
Yeah, thank you very much, Sally, for taking us through that session. I would like to kindly ask the participants to stay with us for probably 10 to 15 minutes so that we can listen to our partners, Crown Healthcare in partnership with Equity Bank. They'll have two brief presentations just to tell us where we can get the devices and support they are giving us during this particular time. So to start, I would like to welcome Vivian Cow, who is the sales manager of MyCom Medical Technology Development Company Limited. She will talk to us about the heated humidifier high flow nasal cannula oxygen therapy device. So Vivian, you are with us, welcome. And if you have a presentation, you can go ahead and share your screen.
Okay, I'm here now.
Thank you and welcome.
So can you hear me?
Yes, we can hear you, Vivian.
Okay, hello everyone. It's my honor to be here to introduce the heated humidified high flow nasal cannula oxygen therapy device. And I'm coming from MyCom Medical. Our authorization distributor is Crown Healthcare. And thank you for your invitation. It's my honor to be here. Okay, so today I would like to introduce, there is a three-part. What's the HFNC therapy, advantage, and the clinical application of the high flow nasal cannula? Okay, first let's see what's HFNC therapy. Okay, so you can see that picture for the brown side. It likes the airway of the patient. The brown side is the mucociliary, and the green side, that's the sputum. So the curve of the humidification therapy is to prevent dryness and makes the mucociliary move to remain effective and clear ability. Okay, let's see how about the advantage. So firstly, the humidity ensures the airway is at the best protection and the mucociliary cleaning is at the best state. The third one, so it allows the sputum to move up and out of the airway. And the last one, reduce the risk of the respiratory infections. And by the way, usually the humidification is associated with heating. Okay, let's see how about the traditional oxygen therapy. So usually the traditional we mean such as the nasal obstruction, nasal cannula mask. And let's see, compare with the high flow, what's the disadvantage about the traditional oxygen therapy? Okay, firstly, the flow rate is much lower than the peak flow rate the adult is inhaling and not enough humidification and warming. As a result, in dry airway, it's leading to dry airway mucosa, and the mask type is poorly tolerated. And there's a difference between the inhaled oxygen flow rate and the transmitted. The amount of oxygen inhaled is not constant and accurate. So let's see how about the advantage of the HFNC. There's 5 points. Firstly, you can see that picture. So it could improve the blood oxygen rapidly and effectively. For this picture, if for 2 patients, the inspiratory demand is 30 liters per minute, Okay, so we can see for this, the left one, they use the high flow device. They could get the 30 liter per minute with oxygen and the air. But for the right one, the right patient, they could get the 5 to 10 liter per minute oxygen and the 20 to 25 liter room air. So in the pack, we can see that's different to the patient. The effective is totally different. And for this picture, it's show the traditional nasal cannula, oxygen cannula, and the high flow. So for the left one, you can see the right part, that's room air, only 21% oxygen, and only a small part, that's 4 liter per minute for the 100% oxygen. So as a result, what does the patient get? That's a variable FiO2. And how about for the high flow therapy patient get? Okay, you can see the whole part. That's the setting FiO2 as the doctor setting. It's the 30 liter per minute. And here we want to say, so the low flow not means the low concentration, because we see here, this part is 100%. And the high flow not means the high concentration, because with the high flow therapy is totally complete 30 liter per minute. The second, the HFNC could wash the dead space by the high flow air, and as the storage room fully reduced the re-inhalation of CO2. There are some pictures took by 2D gamma camera. So if you cannot find the big difference between at the 0.5 seconds, you can see that one at the 2 seconds, the higher flow, the less dead space. And for this wave and table, it shows also that it also improved that. And for this one, you could make it explain the HFNC therapy could work as ventilator CPAP mode. For these two pictures, you see so the pressure level is closely related to the gas flow rate. Whatever the patient, for this one, the left one, the patient is opening the mouth, and the right one, the patient is closed the mouth. Whatever is closed or open the mouth, so the pressure is related to the gas. Here we take this table from a paper. It proved that so the humidification and the heat that ensure protein and the mucociliary gas, also to allow the sputum to move up and out, reduce the risk of respiratory infection. And the most important at the clinical use is more comfortable. It offers the more comfortable user experience to the patient. If you cannula, so without mask, no claustrophobia, cool air and heated. Also, if you use the airflow cannula, the patient could talk, eat, and drink. Okay, so the last one is about the clinical application. So our device could use at different departments, such as not only the respiratory department, also ICU, emergency, and physiology. So it depends on what kind of patient they intend to use. Okay, that's all. Thank you for your attention. And if you have any questions, you could send the message at the chat. Then I could answer you.
Thank you very much, Vivian, for that informative presentation on the device that you have. And thank you for honoring us with that expert presentation on the high flow nasal cannula. So our next presenter is Peter Gikonyo. Peter Gikonyo is going to talk to us on behalf of Equity Bank, who have been partnering with Crown Healthcare, especially during this time of COVID, to try and support the healthcare system in matters of oxygen supply and devices needed for these particular patients. So Peter Gikonyo, Vivian, if you can stop sharing your screen, then we'll invite Peter to make his short presentation.
So thank you, Dr. Susan, and thank you everyone for giving us this opportunity to be part of this call this evening. Actually, we are very grateful. It's quite informative. And from the banks, we can't really say much, just to thank you for the opportunity. In the call, I'm joined in by Winnie, who's our branch manager in Kitengela, and I will be taking you through what maybe we are in it, maybe to offer from the bank side of it. Maybe if Vivian, you can kindly.
Vivian, you can stop sharing your screen. Oh, thank you very much. Yeah.
And I hope my screen is clear, because I'll try to be brief within the minutes which have been given. And the reason for us to be here, maybe from Equity Bank, you have seen as the key objective of Equity Bank is to transform lives, both socially and economically. And in the social aspect, that's why we are coming in strongly, maybe in the within the health sector, to be able to offer the support that which we can. And since we don't have the capacity, maybe to offer the medical and the technical support, we come in from the financial point of it, and maybe partnering with the service providers, and especially now for you, the practitioners, maybe empowering you to be able to support the Kenyans. And we really appreciate the kind gesture that you continuously you continuously offer to Kenyans, especially at this time of COVID. Now, the Equity Bank, we have come up with specific solutions to be able to support you, as sort of already highlighted. And we have noted that being the health sector, being part of the Vision 2030, and also being part of the Big Four agenda of the government, then we can play a key role in terms of ensuring that this is quite achieved. And we have also seen most of your players coming in within this sector, right from expansions, opening your own clinics, and also in terms of training and all things that which pertains to the health sector. And indeed, that's why we have come in to be able to support you. And the key objectives of the bank, why it has formed the health sector, is first of all to try and improve the quality of the healthcare within the country. And how does the quality of the healthcare is improved? Basically, I was listening to what the conversation of today is that if the bank is able to enable and empower you, the practitioners, to be able to acquire these equipments, or the hospitals and the like, then we are improving the quality of the healthcare. Then also the affordability, of course, by increasing the access of this equipment and the finances also, of course, now the affordability of the healthcare is also greatly reduced. This has been occasioned by that the questions which we're asking ourselves is, why is it there is medical tourism in the country? Does it mean that we don't have the enough personnel, or rather the qualified personnel, to be able to offer the services? No. but it's an issue of lack of probably the medical, the infrastructure and the equipment. And that's why we are coming in to be able to support. The other issue is about to encourage adoption of sustainable health services, healthcare services. Of course, now by ensuring that all the infrastructure is required and maybe the support from your side, the practitioners, then we are able to offer these services. And also, again, creating economic value for the healthcare practitioners. We have come up with several products. I'll just give the highlights, and the key one, maybe when I'll be moving into about the medical equipment support. And the first one, we understood that maybe the healthcare practitioners, the first of the thing was to enhance the personal loan offering. This is where we just require your payslip, maybe to support you, maybe for your personal use, or maybe you want to set up your enterprise or things like that. And we have improved maybe the maximum amount of facility that one can be able to access is at a tune of 6.5 million. So we can be able to give you a specialist maybe at a tune of 6.5 million, which is unsecured. Again, we can also enable you to buy your car. We can also enable you to mortgage, maybe to a
Hello, Peter. We have lost you a bit.
Yes, am I there now?
Yes, you're back.
I'll try to summarize. Then the other key element that which we noted also is that you have the mandatory requirements for especially the professional indemnities and other insurance requirements. So as a bank, again, what we said is that we can be able to offer you maybe to be able to pay these the premiums. First of all, we negotiate with the underwriters through our insurance agency so that you can be able to have affordable maybe premiums for all the insurance needs. And again, at the bank side, from the bank side of it, then we allow you, if you don't need to pay it at once, then we can be able to pay on installment basis. So that's why we came up with the insurance premium financing, just to enable you for all the insurance, professional indemnity, all the insurance needs which required. If you have your private enterprise, then we can be able to support you from that side of it. Then the other product, this is where now the Crown Health comes in, that we have partnered with Crown Health. And the main thing is that we are enabling now you as a practitioners that you can be able to acquire most of the medical devices and equipment which they're offering. And we are able to support you up to 80% on that, depending from a case to case. Then we can even push this one to 90 or even some to 95%, depending on the case. So the bank will enable you to be able to have the access of these, maybe the medical devices. You don't need to have all the funds because we understood that this could be costly equipment and you may not have the funds at once. Two, even the ambulances for those who have already have their own private private clinics, that we can enable you to have the ambulances or even the staff buses on what we call the asset financing mode of it. Then in conjunction still with the Crown Health, that if one feels that he wants the Crown Health to do the importation, maybe for certain equipment for them, then we can be able to offer this in what we call the import-based financing, of course on rate of credit mode. Then those who are willing to start off their enterprise, because I mentioned that at the beginning of my presentation, I said that most of you practitioners, one of the goals is that you're shifting, not offering the service throughout, that you want to own up your own enterprise. So as a bank, we are giving this what we call the greenfield financing, of course the startup financing. We can enable you, first of all, to have the access of your own private clinic. Will enable you to, if you already have one which is existing, we can be able to help you in doing the constructions or the development on it, in doing the improvements, which includes maybe doing the installations, if the oxygen, all the installations that which required for the hospital, the equipment will come and visualize the entire project cost is going to be how much, and then we are able to give you the finances for that. Then again, those who would wish, especially in the major towns, that would which probably to acquire the office space and probably fit them out into the hospitals. We are also coming in to support you on that. Then those who already have the existing facilities and there may be challenges of the working capital. Maybe you, especially at this time, you have seen because of the reduced numbers of maybe patients coming into the private hospitals, you might probably been unable to be able to pay probably the workers who are there, maybe the consumables, all the operational costs, you have not been able to meet that. Then the bank will be able to support you in what we call the working capital solutions. This could be tailored, maybe in terms of what we call the term loan. The term loan is where we advance you money and you'll be paying on installment basis per month. Then on the second aspect is when we can allow you to have an overdraft. An overdraft is that we can be allowing you, of course, to be overdrawing your account on a need basis. That is when maybe you have an issue, maybe an urgent issue to be sorted out in terms of meeting your working capital obligations. So those are just the key highlights of what we are offering within the bank from the asset or from the loans point of view, and which we are more than willing to support the healthcare providers, so that you can be able to offer maybe the good services to the country. The others will be coming in, especially now the correction solutions, where we are enabling even integrating your hospital maybe with our bank system, so that you can be able to see the daily transactions, because we understand that mostly your work is to offer the service, not about the initiating the finances. So the bank is coming with an entire package to help you in terms of managing your enterprise, your hospital. You can be able to see all the transactions in real time. You can be able to monitor the liquidity. Maybe this is the money which has been earned today, or maybe in a certain period of time. Then again, also at the final tail end, we have seen with what we are doing with the issuance of the PPEs, that is at the EGF part of it. We organize the entrepreneur programs. So today was just a highlight of what we offer, but we can purely take you on entrepreneurship and the financial management within your enterprise. So we are glad to be part of you this evening. And again, of course, we'll be having more engagements with you, and especially now that we have a platform which we can ride on, that is through the Crown Health Partnership. So that's what I've just mentioned about the funds transfer and the cash management. We can be able to offer you how you can be able to collect the funds from the patients, and maybe using the using the POS, the pay with equity, that is the till number, and the money coming to the account, and of course now through the cards, and especially now doing the integration within your enterprises. Those are just the cards. We can also support you to be able to have, especially the credit cards. These are immediately required, especially when you're making the international travels and such kind of engagements. Then we can be able to enable you to have that. Then the digital loans, what I just mentioned about insurance premium financing, what we were saying about the PI is the professional indemnities. We can enable you, instead of filling the physical forms, then you can just walk into a branch. You can basically use your mobile phone and be able to access this facility using the phone, and be able to repay within maybe within a period of a maximum of 10 months. So that is it. It's just in brief of what we are offering, but most importantly, the equipment that which I just mentioned, that we can be able to facilitate the process. We can enable the process maybe for you to acquire one and be able to pay without major charges. So thank you so much. And I'm very grateful for Equity Bank as well to be given this opportunity to be part of this call this evening. So thank you so much.
So thank you very much, Peter Gikonyo, and on behalf of the Kenya Society of Anesthesiologists and the Critical Society of Kenya, we pass our appreciation to the partnership with the Equity Bank through Crown Healthcare to support the healthcare system and improving quality of care of patients. Yes, so without further ado, we are at 7:38, just on time to conclude our meeting for today. I would like to thank all the participants for being with us. And again, apologies for the technical hitches which were out of our control. Looked like the network was not very good from the side of the speaker, but the slides were quite clear, and I believe most people were able to get the information that was required to be communicated. And with that, I would like again to remind you that the presentation is available on YouTube and on the Kenya Society of Anesthesiologists website. You can go and read and fill in the gaps of knowledge that probably you might not have heard us discussing because of network issues. Thank you, Dr. Kaiser and Dr. Andrew Owuor, for gracing us with your presence and your expert information sharing on this particular subject, where most of us will actually have to learn how to use this device as part of what we do on our daily basis. Thank you again to my co-moderator, Dr. Sally Gitugi, for again helping with the running with of the CME. And lastly, we thank all of you for being patient with us. The tokens for last week presentation have not yet, for the physicians, we have not yet received the CME tokens because the system of the KMPDC is quite slow. Once we get that through, we shall send them to your emails. The rest of the practitioners, I believe you have received your certificates for participation in the CME. So lastly, we shall have our last CME for the year next week. So that will be our winding up CME for the year. So for your planning purposes, look out for the communication from the KSA administrator. Thank you very much. And without further ado, then I would like to close this meeting.